I want to start today's deep dive with a mental image. Imagine you are a detective working a cold case.
Okay, I like where this is going.
You have this suspect, right? And you know they are responsible for a massive amount of damage. But for decades, nobody could agree on what the suspect looked like or even what to call them.
That is a surprisingly accurate way to describe the field of liver disease right now.
And here's the kicker. This suspect is currently hiding inside 1.6 billion people.
Which is roughly 30% of the entire global population.
That number just floors me every time I see it. 30%.
Yeah.
We are talking about a condition that is statistically more common than owning a smartphone in some parts of the world.
It really is staggering.
And yet, the source material we're covering today suggests that our medical system is completely overwhelmed by it.
Overwhelmed is putting it lightly. We're looking at a pivotal 2024 article from the journal Radiographics, and it's titled MASLD, What We Have Learned and Where We Need to Go.
Yeah.
And honestly, it reads less like a standard medical review and more like a manifesto.
It's a total call to action.
Exactly. It's a group of radiologists looking at the data and basically shouting, we have a crisis. The diagnostic tools are chaotic, and we are missing the people who are actually going to die from this.
So today, we are going to play detective. We're going to unpack why the medical world just underwent a massive rebranding of this disease, why it's actually heart condition in disguise, and why the experts are saying our current testing landscape is basically a Tower of Babel that needs to be torn down.
It is a lot to cover, but it fundamentally changes how you should think about your own metabolism.
So let's start with the identity crisis. For as long as I can remember, if you had fat in your liver but you weren't an alcoholic, doctors called it NAFLD.
Right. Non-alcoholic fatty liver disease.
I always hated that name. It feels lazy to me.
How so?
It's like describing a cat as a non-dog. I mean, it tells you what it isn't, but it tells you zero about what it actually is.
Well, that was exactly the criticism that led to this recent change. NAFLD was a term coined back in 1980 by researchers at the Mayo Clinic. They were seeing patients who had livers that looked like they'd been ravaged by alcohol, swollen, fatty, damaged. But the patients swore they didn't drink.
So the definition just became one of exclusion.
Exactly. You aren't this, so you must be that.
Plus, sticking the word fatty right in the middle of a diagnosis feels a little, I don't know, accusatory.
It is stigmatizing, absolutely. Patients hated it. But the bigger issue was the scientific accuracy. The old name implied the liver was just sitting there, passively collecting fat.
Which it isn't.
Right. We now know it's a systemic issue. The liver is just the victim of a much larger metabolic crime.
So in 2023, the medical world holds this massive summit. We're talking 56 countries, 7 different medical societies, and they establish a new umbrella term, SLD, or steatotic liver disease.
And under that umbrella, we get the new name for our primary suspect, MASLD, Metabolic Dysfunction-Associated Steatotic Liver Disease.
Okay, that is a mouthful. It sounds like a bad hand of Scrabble tiles.
It doesn't exactly roll off the tongue, I'll grant you that. Yep. But it is precise. Steatotic is just the medical term for fatty. But the metabolic dysfunction part is the real revolution here.
Because it's not a diagnosis of exclusion anymore.
Exactly. To get this diagnosis now, it's not enough to just say, I don't drink. You have to meet positive criteria.
You have to prove the metabolic connection.
You need to show imaging evidence of fat in the liver, plus at least 1 of 5 cardiometabolic risk factors.
And those are the usual suspects, right? High BMI or waist circumference,
High fasting glucose, or being on diabetes treatment,
high blood pressure.
high plasma triglycerides, or low HDL cholesterol.
So wait, if you have a fatty liver, but you're an Olympic athlete with perfect blood work and low body fat, you don't have MASLD.
Technically, no. You would have what they call cryptogenic steatotic liver disease, which basically translates to, we don't know why you have fat there.
Interesting.
But for the vast majority of people, the liver fat is deeply tied to those metabolic factors.
You know, this rebrand also seems to solve a problem I've always wondered about. The whole non-alcoholic label implies a binary world. You either drink too much or you don't drink at all.
Right, the black and white thinking.
But what about the guy who has diabetes, is overweight, but also enjoys 3 or 4 beers on a Saturday?
The weekend warrior problem.
Yeah.
Yeah, in the old system, they were in a diagnostic limbo. They didn't drink enough to have alcohol-associated liver disease, but they drank too much to be non-alcoholic.
So they just fell through the cracks.
Pretty much.
Mm-hmm.
So the new framework created a subcategory called MET-LD. That's M-E-T-A-L-D.
Metal-LD. That actually sounds kind of cool, like a heavy metal band.
It's definitely the one cool acronym in the bunch. But clinically, it's vital. It acknowledges that you can have MASLD, but also consume higher amounts of alcohol.
And those two things probably don't play nicely
Or
together.
not at all. They
Uh,
essentially team up to damage the liver faster. It's a synergistic toxicity.
Okay, so we've profiled the suspect. We have a better name. But let's talk about the actual threat. Because I think when people hear fat in the liver, they kind of shrug. They think, I have fat on my waist, I have fat on my arms, so what if a little is in my liver?
And that is a very dangerous assumption. Because unlike fat on your waist, fat in the liver isn't just passive storage, it's toxic.
But the source material makes a big point that this is a spectrum, right? I mean, 1.6 billion people aren't dropping dead tomorrow.
Right. About 70% of the people under this umbrella have what we call MASL. MASL, that's just the fat accumulation. No inflammation, no scarring.
Basically a warning light on the dashboard, but the engine is still running smooth.
Great analogy. But then you have the other 20 to 30%. They have MOSH, metabolic dysfunction associated steatohepatitis.
And whenever I hear itis in medicine, I know it means inflammation.
Exactly. Now, the liver cells aren't just full of fat. They're ballooning. They're actively dying. The immune system is attacking the organ.
And when the body attacks itself, you get scars.
Yes. If that rash heals with scarring, that is fibrosis. And if the scarring takes over the structure of the liver to stage 4, that is cirrhosis. And once you hit cirrhosis, you are in real trouble.
But there's a specific group the authors call out, at risk, AH.
Yes, these are the patients clinicians are losing sleep over. They have active inflammation and significant fibrosis, stage 2 or higher.
How many people are we talking about?
They make up about 10% of the MASLD population. These are the ones where the clock is ticking loudly for adverse outcomes.
Now, here is where the article took a turn that I really didn't expect. I assumed, logically, that if you have a progressive liver disease, the thing that kills you is liver failure. Or maybe liver cancer.
That is the intuitive leap, for sure, but it's actually wrong.
So what is the leading cause of death for these patients?
Cardiovascular disease, heart attacks and strokes.
Wait, so liver disease kills you by stopping your heart?
In a way, yes. And this is exactly why the name change to metabolic was so critical. You have to understand that MASLD is not just a liver problem.
Right.
It is the hepatic manifestation of metabolic syndrome. If your metabolism is so broken that your liver is filling with fat and scarring over, your blood vessels are almost certainly inflamed. Your arteries are hardening.
So the liver is basically the canary in the coal mine.
Perfectly said. It's a barometer. If the barometric pressure drops, a storm is coming. If your liver is inflamed from metabolic stress, your heart is directly in the path of that same storm.
The article mentioned it's a bidirectional relationship, too.
Yes, diabetes makes the liver worse, liver makes the diabetes worse, hypertension plays a role, even sleep apnea. They all feed into each other and destroy the cardiovascular system.
That is terrifying, but also really clarifying. It means if you get this diagnosis, you shouldn't just be asking, how is my liver? You should be asking, how is my heart?
Precisely. And we can't ignore cancer either. There is obviously a risk of hepatocellular carcinoma, which is liver cancer. But people with MASLD also have higher rates of extrahepatic cancers.
Like what?
Gastrointestinal cancers, breast cancer. It's a system-wide breakdown.
Which brings us to the demographics. Who is this actually affecting? Because the numbers in the article varied wildly depending on geography.
It's a global crisis, but it's not evenly distributed. Latin America currently has the highest prevalence, 44%,
Nearly half the population.
while Western Europe is the lowest at 25%. But the trend is increasing almost everywhere.
And what about in the U.S.?
In the U.S., there is a distinct racial and ethnic disparity. The Hispanic and Latino population has the highest rate at 23%, while the Black and African American population is the lowest at 13%.
And the article makes a very strong point that we cannot just chalk this up to genetics, right?
Absolutely not.
Uh,
It is heavily linked to social determinants of health, socioeconomic factors, access to care, and especially food insecurity.
If you live in a food desert and the only calories you can afford are highly processed carbs and sugars, your liver is going to pay the price.
It's a disease of environment as much as biology, and a largely silent one. Up to 94% of affected individuals are unaware they have it because it's mostly asymptomatic.
And age is a factor too, or rather, the lack of it. The statistic about pediatrics, I have to admit, that one hurt to read.
It's heartbreaking. Globally, about 10% of children are affected. And we are seeing biopsy-proven steatohepatitis active liver injury in kids as young as 2 years old.
Setting up an entire generation for premature heart disease.
If we don't intervene, yes.
Okay, so we've established the stakes. We have a massive silent epidemic that attacks the heart and liver, affects kids and adults, and is growing. Now we have to find it. This is the toolkit section of our deep dive.
And this is where the detective story gets incredibly frustrating.
Right, because if I go to my doctor today for a physical, what actually happens? Usually they just run a blood panel.
They do. They look at your liver enzymes. And they might use a screening score called the FIB4 index, which combines your age, platelets, and enzymes.
But the authors seem to suggest that's not enough.
It's a triage tool. It's useful for ruling people out, but it's not a perfect diagnostic. The historical gold standard was always a biopsy.
Literally sticking a long needle through the ribs to take a piece of the liver.
Right, which is fine if you have 10 patients.
Yeah.
But you cannot biopsy 1.6 billion people. It's invasive, it hurts, and it has real risks.
So for mass screening, we need imaging, and most people rely on standard ultrasound, the jelly on the belly.
Yes, but conventional ultrasound is purely qualitative. A radiologist looks at the screen and says, that liver looks bright. And a bright liver means fat.
But they can't tell you how much fat.
Exactly. Is it 5%?
Yeah.
20%? Is there early scarring? The standard ultrasound just cannot tell you.
It's like kicking the tires on a car to check the air pressure. You know it's not completely flat, but you have no idea if it's safe to drive on the highway.
That's a great way to put it. Same with standard CT scans or MRIs. They're good at finding fat, but bad at measuring it or finding early fibrosis. And that is why the field is desperate for quantitative imaging. We need a digital tire gauge.
The article talks about some pretty advanced tech here. MRI-PDFF and elastography. Walk us through those.
MRI-PDFF stands for proton density fat fraction. It's the most accurate, non-invasive way to measure fat percentage. Anything over 5% is steatosis. It takes the guesswork out completely.
And elastography.
That measures liver stiffness. Think of a healthy liver like a fresh piece of meat, soft and flexible. A scarred liver is stiff.
So how does the machine measure that without a needle?
It sends waves through the liver, either sound waves using ultrasound or magnetic waves using an MRI. By measuring how fast those waves travel through the tissue, we get a proxy for fibrosis.
That's incredible.
It is. MRE, or magnetic resonance elastography, is the absolute best tool we have for fibrosis. It looks at the whole liver, unlike a biopsy which only samples a tiny, tiny piece.
So wait, we have the technology, we have scanners that can tell us exactly how fatty and stiff the liver is. Why did you start this deep dive by saying the system is broken?
Because having the tools and using them in a coordinated way are two very different things. The authors lay out what they call the 6 unsolved challenges. And reading through them, it really feels like the Wild West out there.
Let's run through them. Challenge number 1 is the proliferation problem.
We simply have too many tests. The article lists 11 different imaging techniques, 24 blood panels, and 6 different omics tests. There is no global consensus on which to use or in what order.
So a doctor in Ohio might order a completely different workup than a doctor in London.
Exactly. It's chaotic, which leads directly to challenge 2, the reproducibility problem.
This is the one about the machine brands, right?
Yes. MRI and MRE are very consistent across different machines, but ultrasound is not. Measurements vary significantly depending on whether the clinic bought a GE machine, a Siemens machine, or a Philips machine.
That is insane. So if I get scanned today on a GE and next year on a Siemens, my numbers might change just because of the vendor's algorithm?
Yes. It makes tracking a patient's disease over time remarkably difficult if they switch clinics.
Then there is the reporting problem. And this one feels like a massive missed opportunity for early intervention.
It really is. Radiologists see fatty livers, incidentally, on scans all the time. Someone comes in for a CT scan for kidney stones or appendicitis, and the radiologist can clearly see the steatosis.
But they don't say anything.
Often they don't report it, or they just write fatty liver in the notes without flagging it as a metabolic risk. There are no standardized guidelines for these incidental findings yet.
So the patient walks out thinking they are perfectly fine.
Right, missing the chance to turn things around early.
Now, I want to get to the 4th challenge because this is the one that really scared me. The authors call it the needle in the haystack problem.
This is the single most daunting clinical challenge we face. Imagine the haystack is the 1.6 billion people with MASLD. Somewhere in that haystack are the specific individuals who are going to develop liver cancer.
But usually the rule with liver disease is healthy liver, then scarring, then cirrhosis, and then cancer, right? So you just screen the cirrhosis patients.
That is how we handle hepatitis C and alcohol-associated disease.
Yeah.
But MSLD breaks the rules. The data shows that roughly one-third of liver cancers in MSLD patients happen in people who do not have cirrhosis.
Wait, let me make sure I understand that. Their liver isn't fully scarred over. They don't look like a terminal patient, but they still develop a tumor.
Yes, they might have some inflammation, maybe mild fibrosis, but no cirrhosis.
That is terrifying, because if standard guidelines say only screen the cirrhosis patients.
Then we are blind to 30% of the cancers until it's too late. But we obviously cannot put 1 billion people through expensive MRI screenings every 6 months. We need to find the needle before the tumor grows.
Which ties into Challenge 5, the availability problem. Advanced MRI is expensive and hard to access.
Right. If you live in a rural area, you aren't getting an MRE. But there is hope here. We're seeing development in point-of-care technology.
Like what?
Handheld ultrasounds with AI guidance, even portable tabletop MRI devices.
So a nurse could just use a device the size of a phone right in the general practitioner's office.
Exactly. And another solution is using AI to extract fat and stiffness data from routine MRI scans done for other reasons without needing any special hardware.
And the final challenge is the knowledge problem. The article admits we still have massive gaps. We don't even know the true global incidence in children or the exact sequence of tests to run.
Which brings us to the climax of the article's argument, the role of radiology.
Yeah, the gap here was shocking.
Since 2010, there have been 30 clinical practice guidelines published globally for this disease. 459 authors contributed.
459 experts. How many were radiologists?
2.
2 out of 459.
And 0 radiology societies participated.
That seems completely backward. We just spent this entire time talking about how advanced imaging is the future of diagnosis. How are the people running the machines not invited to the meeting?
It's a systemic failure. Hepatologists and endocrinologists are writing the guidelines, but they aren't experts in the physics of imaging. So the guidelines recommend outdated pathways because they simply don't know what modern radiologists can do.
So this paper is basically a rallying cry.
It's a plea. They are telling their colleagues, stop hiding in the dark room reading scans, demand a seat at the table, help create the standardized reporting, or this crisis is going to crush the healthcare system.
It really paints a vivid picture. So to bring this all back home for the listener, we've covered the name change from NAFLD to MASLD, the hidden heart risks, the cancer mystery, and this broken testing system. If you're listening to this and wondering what to do with this information, what is the big takeaway?
The takeaway is that your liver is a metabolic barometer. Don't think of it as just a passive filter. If you have MASLD, your body is shouting at you that your overall metabolic health is under stress. It is a major red flag for future heart disease.
But it's not a death sentence.
No, absolutely not. The early stages, MASL and early MAH, are potentially reversible. Lifestyle changes, weight management, getting your blood sugar under control. You can turn the ship around. But you have to know you are on the ship.
And for the big picture, the future of how we view this disease.
I think we need to obsess over that needle in the haystack problem. That finding about cancer occurring without cirrhosis is profound.
It really messes with the standard timeline of how we think cancer works.
It does. It raises a really provocative question. For a long time, we thought cancer was caused by structural damage, the scar tissue mutating the cells. But if you can get cancer without the heavy scarring, it suggests that maybe the soil matters more than the structure. The metabolic environment, the inflammation, the insulin resistance, the high lipids in the blood. Maybe the toxic soup is driving the cancer directly, regardless of what the physical liver tissue looks like.
So we need to stop treating organs in isolation and start treating the whole metabolic system. Well, it's a sobering thought, but definitely a hopeful one if it leads to better prevention. This has been a fascinating deep dive.
It's a complex topic, but a vital one.
Thanks for helping us decode it. And thank you to everyone listening. Keep an eye on your metabolic health, and we will catch you on the next deep dive.